I have to open here on my own. This transition is not occurring from here. No? You want me to use this? Okay. So after Bhavin has told you that you should look for lung cancer in people who have been smokers, we'll briefly touch upon when do you suspect lung cancer and several things more about its imaging spectrum. So what happens is that lung cancer can have a typical appearance and an atypical appearance. So it's not only, asymptomatic people in whom you are doing an opportunistic screening. Mostly we will be confronted with people who are symptomatic and we have performed imaging of any sorts. And here the issue is that the symptoms of several things, including tuberculosis, infections, other infections, and CA lung can be similar. So there are so many mimics that are enlisted. I've divided these imaging spectrum into two types, which is to say that this is a classical appearance and this is an atypical or less frequent appearance. Obviously, when the appearance is atypical or less frequent is the time that you are likely to miss it and call it something else, which leads to delayed diagnosis. Broadly, the classical appearance divides it into central and peripheral tumors. From a teaching point of view, what is the definition of a central tumor? Up to the segmental bronchi. So which means main lobar segmental and inner 2/3 of lung remains central and the rest beyond that are called peripheral. And from clinically, what can central tumors come to you like? They can come to you like a hilar mass. They can come with the central mass with the distal collapse, or simply that the collapse is the dominating factor, like here, it comes with an opaque hemithorax. So this is the classical appearance of central masses. And this is the CT scan illustrating pretty much the same, that you have a hilar mass, you have a lot of mediastinal nodes. When we come to staging, Mandeep will address how, differentiation between central masses and nodes can be challenging. And similarly, you have distal collapse. So this is the typical appearance for a central mass lesion. In peripheral tumors, the story becomes more diverse, especially since the screening programs came. Earlier, we would refer to them, solid masses with speculated appearance and pleural tags, etc. But with early lung cancer, there is a lot of emphasis on part solid nodules and features in part solid nodules, which should help you detect malignancy. So there are many features such as pseudo-cavitation signs, bubble sign, etc., which should help make you suspect that this is malignant. So this is example of an air bronchogram, which is otherwise classical of infective consolidation and cavitary mass, which are easy to mistake for infection. So these are the classical picture that we are used to. But now I'm going to address the issue of once having diagnosed CA lung, as we move into the era of radiomics, how much machine-based feature extraction or human being based can actually help in subtype prediction. And is subtype prediction your role at all? So it is actually, because as you would have seen, even after the histopathology, many times the histopathologist can also have a dilemma. So it does help to say that if you can predict the subtype, the first main subtype prediction is differentiating the epithelial from the neuroendocrine variant, which means is it NSCLC or is it a small cell carcinoma? So the first differentiating type is differentiating small cell versus non-small cell, which is summarize some of the points that I brought out. One, famous is that you have a small peripheral tumor and you have huge mediastinal nodes. But that's not the only thing. The small cell tumors, when they are peripheral masses, do not show speculation very often. I'll show you another sign which is seen with small cell carcinoma, which is the peribronchial spread. If you see this case below, the peribronchial spread, which goes along the central bronchi, is very characteristic of small cell carcinoma. On the other hand, pleural spread is very infrequent with small cell carcinoma. So this is the main, first step towards, say, subtype. Then the next step comes, can you tell an adenocarcinoma versus a squamous cell carcinoma? We are aware that cavitation is classically described more in squamous cell carcinoma. We are now on peripheral tumors because central tumors are really difficult to tell. On the other hand, presence of air bronchogram, bubble-like lucency, pseudocavitation, and part solid nodules are characteristic of adenocarcinoma. So the fun differentiation you did was squamous versus adeno. So here are some examples to show you the differentiating points. Squamous has the characteristic peripheral thick-walled mass-like lesion. And then, but look at the spectrum that the adenocarcinoma can show you. Part solid nodules, small bubble lucencies inside, and then large areas of consolidation, cavities with just a little eccentric wall thickening. The last one is a patient of invasive mucinous adenocarcinoma. So this was differentiation between adeno and squamous, but that's not the only differentiation. Now I'm going to go further into the subtype differentiation. Now, if you look at the WHO classification, we divide the adenocarcinoma into pre-invasive, minimally invasive, and then overtly invasive. Apart from, even in the pre-invasive, the moment you start from adenocarcinoma in situ or AIS, the mucinous versus non-mucinous categories start. So can you predict mucinous versus non-mucinous? And then I will come to the various grades of invasion that you can predict on imaging. So if we come to subsolid nodules, you know that nodules which show you a mixed solid plus ground glass component have a higher chance of being malignant. And as the solid component goes up, so does the likelihood of malignancy. And several of these pre-invasive and minimally invasive lesions may not be PET avid. So that's the need to, recognize them early and sample. So if we look at the grades of invasiveness and how the appearance will change. So from the first category is AIS, then minimally invasive, and then at the other end is invasive mucinous. In between are lipidic predominant or called LPA. So I've given two examples of MIA on top and LPA at the bottom. So the MIA can look like, a purely solid ground glass also with hardly any ground glass nodule with hardly any solid component. And the one which I've been showing you throughout with pseudocavitation was a lipidic predominant. Pseudocavitation or bubble lucencies are characteristic of the lipidic pattern of growth. Now, if you look at the next one, this one is the one which, is most likely to be missed because this will come as multiple nodules, consolidation, and especially if you do an MR on them, this really bright T2 hyperintensity. And now we are so familiar with this entity that whenever we see somebody who's 30 something and has a non-resolving multifocal consolidation, we say, is there bronchoria? This is mucinous adenocarcinoma. Most likely these are mucinous adenocarcinomas. So next differentiation that you can do is mucinous versus non-mucinous. So if you look at the differentiating points of mucinous versus non-mucinous, air bronchograms, bubble lucency, CT angiogram sign, because like if you see in the previous patient also, which I showed you, this is a non-contrast scan. If you do contrast enhance, these consolidations are very low density and the CT angiogram sign really shines out amongst them. So this pattern of mucinous is also very easily predicted on imaging. This is another example of mucinous adenocarcinoma, and which happens in young people more often, and several of them are non-smokers. But this patient also has a left main pulmonary artery embolism or thrombus consequent to the malignancy. So this is the next step that you can predict. Can you predict the driver mutation? So you know that now radiomics are focusing on, if you look at the spectrum that we get in India of advanced NSCLC, all the studies and whatever data we have analyzed of our CT and PET, we have not found anything significant. And most of the literature, talks about differentiation in early stage lung cancer. In advanced stage, it's very difficult to predict the driver mutation. Although, overall, when these are EGFR positive tumors, then hematogenous spread is more frequent, lymph node metastases are less frequent, but it's difficult as of now, at least in advanced carcinomas, to predict EGFR or ROS mutation. And so that is, now I'll come to the next thing, which I told you of missed lung cancers, that atypical appearances. We've seen some typical, we've seen some subtyping. So this is a patient in whom was a regular follow-up patient, but we missed the lung cancer. So I always carry it. It was a mistake made. This is a 75-year-old patient who was on UIP follow-up. And I zoomed these images out because we made the diagnosis when the last scan happened in July 2018, and we sampled and it came out as squamous cell carcinoma. But actually, if you look at October 2017 compared to 16, we should have predicted it at that time, because there was a bit of eccentric wall thickening which was beginning to happen in the anterior wall in October. And unfortunately, the interim 1 year, not even 1 year, 10 months that it passed, it became an advanced lung carcinoma because patient had huge mediastinal nodes. And he was on antifibrotics. So every year we were almost doing a scan on him. So this is the classification, one of the commonest missed lung cancers are cystic airspace associated lung cancers. And there's a classification of the patterns by Masachi et al. You can go through that in detail of various types of appearances which come. And one more such example, this is not really cystic space. This is like a patient who kept getting treated like a ruptured hydatid for long till patient came to us. To be fair to them, initially the pleural thickening and wall thickening was not so gross, but the moment you look at it, this is CA lung, and this is a patient we did last month, and it did come out to be adenocarcinoma eventually. So cavities and cysts are one of the commonest reasons of missed lung cancer. Another patient we missed about 15 years back. She was also being treated as tuberculosis for long. Now we know that these are, bubble lucencies. Over a period of time, this cavity wall kept on thickening, and she came with anterior abdominal wall metastasis. She was a scientist with us, 36 years old. So cystic space associated lung cancers are one entity which are missed. The other entity you tend to miss are scar carcinomas in setting of silicosis, in setting of tuberculosis. So scar carcinomas also you need to, watch out for. Whenever you have an increase in size, increase in ground glass, new speculations, you have to be aware. So to summarize, what radiomics promises to offer and what you can with human reading offer currently is benign versus malignant differentiation, predicting a mucinous adenocarcinoma, predicting the degree of invasiveness and histological subtype, and identifying high-risk lesions, of course, in LCS setting. I have not put the driver mutation here because I don't think we are there yet. So thank you very much. Questions?